It's 1300 hours here, so I'm going to start on time. Hello, everybody, friends and colleagues alike from different time zones. You are now in the GICS Pediatric Trauma webinar, and a huge thank you to the panelists and the organizers within the webinar. If the person I mentioned can just wave. So Sabina is the lead for education for GICS. We have Abdelbasit, who leads the Pediatric Trauma Committee for GICS. And then we have our panelists, Soji, who many of you know. We have Warwick Teague, one of our panelists, and we've got Simone from Brazil. So hi, Simone. The way we're going to run the webinar is we're going to have two speakers, first looking at the global need in trauma and where does the land lie with trauma on a global level, followed by the preventative mechanisms for trauma in children, followed by primary health care. At the end of this, if you have a question, please post it on the chat and we'll pick it up and direct it through. Also, at the end, we will be sending you a survey, and on completion of the survey, you will get a certificate which has CME points. It will count towards your education profile. And before we kick off, not forgetting Maggie, who's hidden herself in the background, who's doing all the administrative work and making sure that none of us are naughty and running over time and everyone is behaving on this webinar. So to avoid any delays, we'll start off with Soji, who will be talking to us about global pediatric trauma and overview. You're muted, Soji.
Can you hear me now? Hello?
Yes, we hear you. We hear you.
Thank you. Thank you. So good afternoon to the audience from all over the world. My name is Adesoji Ademuyiwa. I would like to share my screen. And I'll be discussing very briefly the global pediatric trauma burden. I am a pediatric surgeon at the Lagos University Teaching Hospital in Nigeria. And I will be discussing the importance of childhood trauma, what the mortality is across the world, what are the important causes of trauma, and then the modest contribution of GICS in addressing the menace. Trauma is important because every year we have 950,000 children dying from injury and violence. And that is equivalent of 5 jumbo jet crashes a day, or 1 to 2 deaths every minute. So by the time I finish this presentation, 5 to 10 children across the world would have died from trauma. And by the time we finish the webinar, between 60 and 120 children would have died. That is a real cause for concern. Majority of this mortality is borne by low and middle income countries, particularly in Africa and Asia. But the more important message is that majority of the causes are preventable. So something can actually be done about it. So it's important, this bar chart is just to show that the death due to trauma increases with age from birth. So within the first year, because the care of the parents, particularly the mother, is so much, death due to trauma is less than 2%. But as the children grow and they get to teenage years, then that increases. As we can see, that blue line, it increases across the age range. Now, the mortality from trauma in 2000, we will see that majority of it is concentrated around the Middle East and northwest of South America, with those dark dots. About 12% of all deaths in this country. So it's not only pediatric trauma, and this is actually data from the WHO. However, if you look at 2019 data, we'll see that many more countries in Libya, Ethiopia, South Africa have now joined this group. So the mortality seems to be increasing. And this is well represented in the next slide as the hotspots of the world where trauma seems to be very, very high in contributing to mortality. What are the causes of death? This is a busy slide, but I believe that it's clear enough. In the first 1 year of life, trauma does not show up like we had seen before, but as they begin to grow, then drowning and road traffic injuries become very, very significant, as well as burns. And then in the teenage years, we'll see that road traffic injury and drowning are the prominent causes of death, such that in globally under 20 years, road traffic injury, drowning, and burns are the main causes of death, and majority of these are preventable. And essentially the same thing, except to say that self-harm and interpersonal violence are also significant in certain areas of the world. GICS has contributed to addressing this menace by identifying trauma as a major intervention project, and a trauma committee, and this committee, the committee is organizing this webinar, and they've produced information leaflets on prevention of childhood injuries. They are collaborating with the WHO to produce the pediatric trauma model. And then some of the things we are going to be hearing about the trauma care course, GICS is also ensuring that that also includes children. I would like to stop here and say thank you and hand over to Abdelbasit. Thank you very much.
Abdel, you want to share your slides?
Yeah. Right. Yeah. Thanks, Buhila, and thanks, Soji. I'm Abdelbasit E Ali. I'm a consultant pediatric surgeon, King Saud Medical City in Saudi, and a consultant pediatric surgeon, Sobe University Hospital in Khartoum, Sudan. And good day, everybody. Trauma remains a major health threat to children, as you heard from Soji. It's a major health problem universally and indiscriminately. The trauma has been a neglected form of injury for many years, and a health problem for many years. And these are largely absent from the child survival initiatives on the global agenda, unfortunately. Slide is jumped. So who cares? As professionals, we all care for children with trauma, but we lack, or most of us actually lack to care for trauma care for children. In other words, lack of specialty ownership in pediatric trauma. Now, with the development of healthcare systems, people have realized the importance of specialization and integrated services. And this typically applies to trauma services, particularly in the fields of management of severe trauma and multiple injuries, as we have seen in the several protocols and guidelines by different organizations, such as the WHO. Such trauma services and such organized services have resulted in reduction of casualties and or mitigation of trauma consequences in the high-income countries. In low-income countries, or most of the low and middle-income countries, however, the situation is still far lagging behind due to lack of dedicated, responsible authorities necessary for coordination of a comprehensive approach to this problem. So pediatric trauma is in no man's land. It's an orphan. Services are not organized or coordinated. Subspecialties management is scanty and fragmented. Many healthcare workers all over the world suffer from many problems to deal with pediatric trauma, such as lack of registry for strategic planning, shortage in trained staff, lack of political will, lack of funding, and poor infrastructure. So how can we make a positive impact? This is a global problem which requires a global and a comprehensive approach for its management. And this is a justification for GICS to launch its Children's Trauma Care initiative, which essentially is an advocacy for encouraging specialization in pediatric trauma. We know there are many trauma courses and trauma course certified healthcare workers. However, what we seek to achieve is to encourage local champions to adopt a children's trauma ownership program. And these champions should be equipped with the interest, the desire to dealing with these problems. They should have the vision, the enthusiasm, the courage, and the perseverance. To work through assessing their local resources to tackle the problems, and they should be able to reach out for decision makers and local authorities and utilize networks for external assistance and collaboration. The spectrum of the program includes most of the problems or aspects related to trauma, starting from prevention, not ending with it. The importance of which is going to be presented by Professor Simone in the next talk. We should aim at improving the first aid training for society and for healthcare workers. We should aim at getting an appropriate pre-hospital primary trauma care, including good ambulances. All in-hospital requirements, from trauma reception, resuscitation, through diagnostic facilities, OR equipment, and advanced care in pediatric intensive care units, and provision of specialized surgical services and subspecialties, and not ending with rehabilitation. And parallel with all that, there should be a good registry, research, and guideline setting. And the end aim is to end up with specialization in pediatric trauma, such as that available in adult trauma. These are some of the leaders of the group of pediatric trauma of GICS. And as Sogi mentioned, the group had been undertaking many activities, including production of the trauma prevention leaflets, which had been uploaded in the GICS website. The group had been involved with several activities and events and paper publications, including presentation to the United Nations General Assembly for awareness in its 75th meeting. So there is a genuine need to draw attention of all stakeholders to the importance of proper and focused training of healthcare workers to tackle the problem of pediatric trauma, There is a need for a great deal of political will. There is a need for allocation of funds to hospitals and all healthcare facilities that provide pediatric trauma services. And in conclusion, GICS Children's Trauma Care Initiative encourages self-acquisition of pediatric trauma care ownership by local champions, aiming to carry out tasks to achieve a comprehensive service and development in this often neglected field, particularly in the low and middle income countries. Thank you very much.
Thank you, Abdelbasit. We shall now that we have the overview from two of our colleagues, we'll move on to the important factor of prevention. So, Simone, the floor is yours.
Thank you. Just let me share my screen, just a moment. Can you confirm, please, that you can see this and hear me?
Yes, we can hear you and see your screen very clearly.
Thank you. So thank you so much for the opportunity of being with you here to talk on such an important topic. And I am a professor of pediatric surgery in São Paulo, Brazil. And I was the former president of an NGO devoted to trauma prevention in children, which is called Criança Segura. And I will tell you some of our achievements. So, as already being said, according to the WHO, there might be an overwhelming increase of childhood deaths due to environmental changes and enhancement of the risk exposure in trauma, which is the leading cause of death throughout the world for children until 14 years of age. But the good news is that 90% of those deaths can be prevented. In Brazil, trauma is the leading cause also. Around 4,000 children die annually in this age, and 122,000 are hospitalized. And we estimate that for every child that dies, 4 children might have permanent sequelae, which brings us challenges on finances from a social point of view, and of course, an emotion. It's a huge impact for the family and for the individual. So as you can see, we are overwhelmed with violence news every day, but this is not what impacts. So here you can see from a national database in Brazil that the so-called accidents are the first cause of deaths in children. And if we stratify a bit the causes, it agrees with what has just been said. So traffic and drowning are the main causes, followed by burns, firearms, poisoning, accidents with animals, and others. If we look at age, you can see that drowning and traffic are the most important from 1 to 14 years of age. But below 1 year, suffocation is the most important preventable deaths. As for hospitalizations, again, accidents are the most important cause and not violence. And here, the main cause, so if you did not die, you should be a victim of falls mainly, and followed by these other causes. And here, for hospitalizations, everything is the same. You see, falls are the main cause. So in Brazil, 375 hospitalizations for pediatric trauma occur every day. And we have many challenges on pediatric trauma care. So everywhere, when a child is traumatized in the pre-hospital or hospital phase, everybody is very moved, and they forget that they are able to do many simple things that might guarantee that this child should be well taken care of. And I'm sure that this will be better explored in the next talk. And there is not, in adult trauma, we could organize ourselves in the recent 40 years, more or less, on complexity hospitals, on where should the patient be transferred for, depending on the severity. But this did not happen yet for children. So where should the traumatized child be treated? What's the ideal structure of care? How can we train and keep people trained to give adequate treatment and to traumatized children? And how to standardize resources. So here in my country, children that suffer from trauma, they can be cared in hospitals with or without pediatric ICUs and wards, in pediatric hospitals, in general hospitals with pediatric wards, with or without pediatric specialists, and pediatric specialists committed to trauma are very few. But what we see is, this was a child that I cared for some years ago, and he was run by a bus, and he almost died through a hemorrhage that you can see an open book fracture in the pelvis. He almost lost his testicles. He had a colostomy and a urinary diversion. He was in hospital for 4 months, and it took this child of 7 years old 6 months to get back to walking. And this brings a huge burden, not only for the child, but siblings feel like they are left aside. Parents lose their jobs. Parents divorce. So it's a nightmare that can be easily prevented. And also, it is on the children's rights that a child should be cared for first in case of a multiple victim causality. So in pre-hospital, this is some studies that we did here in Brazil. So in São Paulo, we looked for a database for the pre-hospital care system, and we analyzed 17,000 cases of children above 18 years of age. And we designed this dispatch system for the advanced unit. And although what we saw is that although they were being adequately used, we could enhance 30% in a very costly resource. And when the national pre-hospital system was launched, we interviewed doctors from all over the country, and you can see that half of them did not feel prepared to care for traumatized children. 35% had difficulties in making a physical exam in a child, and 63% were insecure. And it's our fault, because if we think it's an accident, it seems that we have nothing to do. The other thing is that we think that it won't happen to me, and we neglect many of the very basic safety actions that we should take. We forget that children learn from models and not from people telling them what to do. And we think that people know the obvious, but they don't. And we surgeons like to operate trauma and not to invest in prevention. Until the moment that you do everything right and the child that was before very normal becomes with a permanent sequelae. And prevention involves all members of society. So this is a change of behavior. And you should be able to see prevention as a vaccine and not as a boring thing that a surgeon should work on. So I'll forward now some images in which you can identify how simple this is. So preventing falls like this is very common here in my country, a slab fall, which is very severe. Testing the temperature of the water before putting your child on bathing. It's very simple, otherwise you can have a very severe burn. This also goes for feeding, when you warm the food for the children. Leaving little children being cared for smaller children. So this is another problem for suffocation. Securing windows and stairs. Be careful with pedestrian injuries, be aware of those. Not letting fire guns and cutting objects near the children. Be aware of carpets like this to prevent falls. Very simple things. Pen handles to the wall and not to the child. Not letting cleaning products that in the most social challenges that we have in low and middle income countries. Some people buy cleaning products and leave it on PET bottles, so the child thinks that they can drink them. And this is a major cause of problems. Tiny objects. The washing tank should be fixed to the wall. And this is the real situation. The television in small plans that can bring a similar trauma. Protect stairs, as I already saw, or electrical burns, which are very severe. Drowning. Children on the front seat should not be able to travel like that, of course, because of this. And for the moms that think that they are able to secure their child without a proper safety device, you should show them those videos, right? And also for cycling. And the cutting waxes that people use on kites can also provoke many. So how can we prevent this? I'll just share something that we did here. So Criança Segura, which is Safe Kids Brazil, is in Brazil since 2001. And is part of a worldwide organization in 30 countries. And we were able to lower 53% of the deaths in the country by educating people for trauma. So we worked on 3 pillars: communication, mobilization, and public policy. And these are some images that you can see that we did. We form parents, teachers, healthcare, and traffic professionals, and communities. And this is of essence for having partnership with the government. We developed many interesting and colorful material, didactic material, and also developed an online course on trauma prevention. And these are our results. Some of the initiatives, pictures. This is one here in São Paulo some years ago, in parks. And we use the media as an ally. And we were able to reach the main vehicles in the country. And also we were able to bring some new laws on vehicle transportation in children, child walkers prohibition, liquid alcohol, and due to the pandemic, this was a problem again. And also work on research. So mother's perception on behavior about prevention. Why don't people use safety devices after the law? We did a research in 5 hospitals here in São Paulo. And we were able to see that most of the families of injured child had $220 income a month. Many of the children were alone at the moment of trauma, and the epidemiology is in agreement with what I have just seen you in the official data of the country. 8.5% of children had severeness criteria, and those were the risk factors for severity. I had the privilege of being the Gil Greenwood lecturer last year, and recently we have published a paper based on the talk. I would like to invite you to come to that. And Criança Segura has had recent changes and was embraced by SOS Children's Village here in Brazil. And so our legacy is very well taken care of, and we are very thankful for that. We are also working on an intersectory intervention to prevent non-intentional injuries in a very social challenging area here in São Paulo. And we intend to do actions in schools, houses, hospitals, and involve community agencies. And this is, we trained 350 community agents for this. And we also are very, very happy that both GICS and the Global Children's Non-Communicable Diseases groups from Oxford have embraced prevention as a very important topic. And I would like to invite you all to visit the GICS webpage, where you can address some of the already built prevention guides that were developed. So in conclusion, please be aware of local epidemiology, because reliable data is of essence to guide our actions. Work on the vaccine, that is prevention, and involve governmental authorities. Train pediatric advanced trauma care and check if you have the material needed available wherever you work. And by training and working on prevention, you really can make the difference. I'm sure that the next talk will talk further on that. And with that, I thank you very much for your attention. Thank you. I'm happy to take questions.
Thank you, Simone. What I'm going to do is leave the questions for the general discussion. So thank you for that very inspiring presentation. We'll now move on to Warwick Teague, who will speak to us about pediatric primary trauma care. And as you notice, we are concentrating a lot on primary care and prevention, which are the pillars of trauma care in terms of children as well as adults.
Thank you, Keela, and thank you, Simone, for your excellent presentation on the prevention of childhood injury. This is a very confronting scene for most people. For many, it will also be a scene that will create fear when a severely injured child arrives in their department or in their environment, at the roadside, for example, for pre-hospital practitioners. And that fear is in many aspects based around unfamiliarity. There's the fear of the unknown. Even though perhaps you are a practitioner with experience in adult medicine and the delivery of care to injured adults, the arrival of an injured child throws all of your knowledge to one side and becomes very confronting. In that setting, it can become chaotic, errors can arise, and in that madness and badness, the experience for the child, the parent, and the team that are gathered around with sincere want to deliver good care can be one of a negativity, a sadness. We are aware of the high risk of death for some severely injured children. We are aware that trauma is the #1 killer of children in many settings. And so we are worried about the prospect of severe injury leading to death or disability. But what is it that saves lives in this situation? It is not particularly clever or skillful individuals. In fact, it is a highly structured and systematic approach. It is a structured approach which calls upon strict priorities, which will be familiar to many of you. It is a systematic approach which enforces and imbibes strictly pediatric approaches to this injured patient. There may be similarities with the way that you approach an adult, or there may be important differences. And we're going to highlight some of those similarities and differences in today's talk. It is a team sport, and teams caring for injured children, as they are also caring for injured adults, should be prepared and practiced. And one of the elements they should be practiced in is procedural competency. And at the end, I'm hoping to be able to unpack and demystify some of the procedures that might save a child's life. It is really important that we understand that whilst trauma may be our core business, the injured child insists upon us that we may not be able to simply go about our business as usual, because every aspect of this care needs to be pediatric in the way in which it is delivered, the expertise that deliver it, the skill sets and the philosophies that underpin it, and the experience of the injured child, which sits at the center of this trauma care moment. So as we think about the prioritization of the structures and the systems with which we respond to a severely injured child, I want to run through the A, B, C, D, E, and then T standing for tests and tubes in the care of these children. I want to highlight ways in which children are perhaps different or maybe similar to adults to enable you to deliver better care to the severely injured child when you next care for them. So if we think about A being for airway, it is well understood that a child's airway is prone to obstruction. And sometimes we think about that because the airway is smaller and therefore, for example, more prone to the relative changes of edema. But I want to actually highlight something that is bigger about a child, and that is that they have a relatively bigger occiput on their head. And the consequence of that relatively bigger occiput is it tips the flat line, the supine child, it tips their neck into relative flexion. It takes away the neutral position of the spine, something which we are trying to achieve, a neutral position of the spine to care for the potential for cervical spine injury in this child. It also brings the airway into a kink and increasing the obstruction of that airway. So for both of those reasons, we want to be able to take away the impact of the occiput, take away the flexion that it imposes on the neck. And the way we achieve that is to elevate the thorax, a thoracic elevation device. Now, a thoracic elevation device does not need to be something complicated. In fact, as seen here, it is simply a towel folded several times. And that elevates the thorax of this child. And up until the age of 8, it is typical that the thorax of a child will need to be elevated to open their airway to maintain a neutral position of the spine. It's a very simple and effective way to start off this child's prioritized systematic care excellently. Going beyond that and thinking about other aspects of A, we think about the cervical spine and the spine along all its length. And there are many ways in which cervical spinal injury and spinal injury differ between children and adults. That relates to the anatomy of the spine in the child and the mechanisms with which children who do sustain a cervical spinal injury do so. And we'll highlight that they are often very high levels of injury compared with the levels at relatively lower levels of injury seen in adults. And in and around the assessment of this child, understanding, can they be formally assessed? Can that spine be cleared? We may need to arrive at a decision as to whether we're going to use a collar. And whilst we can't go soft on the potential for cervical spinal injury or other spinal injury, we should go soft on spinal collars. And what do I mean by that? I mean that in many trauma systems worldwide, the trauma system which I work in being one example, we have now gone well away from the use of hard, rigid collars towards soft collars. And examples of the appearance of a soft collar is given here. The emphasis is no longer on spine immobilization because there is a recognition that we were never really achieving spine immobilization. They were words we used, but it was never an outcome we particularly achieved. And not only that, but the attempts to achieve spine immobilization through using a hard collar was exposing children, particularly the youngest of children, to the potential for secondary injury in and around the spine, and secondary injuries such as pressure and venous injury or venous congestion. Now, all of this was a negative against the fact that we were failing to achieve the positive of spine immobilization. So our actions have changed towards using a soft collar, and our language has changed towards talking about spine restriction of spinal movement. And that is where we need to be focusing. And for those reasons, we strongly recommend, whether it's in the pre-hospital or hospital setting, in this undifferentiated, uncleared spine, that we use a soft collar. Of course, the experts in spinal trauma management, be that a neurosurgeon or an orthopedic surgeon, they may wish to recommend some of the semi-rigid collars, such as a Philadelphia or Aspen collar. That's a specialist recommendation. I'm not in any way contradicting that. I'm talking about the undifferentiated child whose spine is not yet to be cleared. In that child, we can use a soft collar for maximal benefit overall. Moving now down the prioritization from A to B, what is there around the chest that we could highlight in the child? Well, firstly, chest trauma in children who are severely injured is common and dangerous. It is a common cause of severe injury and is a common cause of death in those children. And when we look at the experience of our hospital and the children who have severe chest injury that we receive, we find that about 2 in 3 have a lung bruising or lung contusion. Even though rib fractures are often thought to be uncommon because of the compliant nature of the child's bones, we see in that subgroup 1 in 3 have rib fractures and 1 in 4 have a pneumothorax of some kind. Thankfully, the more serious clinical scenarios of a significant hemothorax is less common, 1 in 10, and even less common again is the intervention demanding situation of a tension pneumothorax, 3 in 100. And the key question we need to be asking here is, does this child need life-saving pleural decompression, either around a suspected or known chest injury, or perhaps in the setting of traumatic cardiac arrest? And we're going to park that question. And later in the presentation, I'm looking forward to talking to you about some tips on pleural decompression and explain to you why I say it's a kind of magic. When we think about the circulatory assessment, it is often correctly highlighted that children can maintain a normal blood pressure, a blood pressure within the normal range, despite losing significant volumes of blood. And it's that compensation which helps to protect the child's physiology from the consequence of the injury that they've sustained, even in the setting of significant blood loss. Now, that blood pressure compensation is excellent, but if it is to fail because the body can no longer compensate, then that child with the low blood pressure, they are on a precipitous decline. They are in pericardiac arrest situation. So it is great when they compensate, but it is terrible when they can no longer compensate, because that reflects a child whose physiology is very embarrassed in the setting of typically in the setting of hypovolemic shock. But there can be some other contributors in the setting of severe trauma. So to make sense of a child's heart rate, of their blood pressure, we have to recognize that at different ages, a child's blood pressure or heart rate has different expected normal ranges. So we can't just take our business as usual adult idea and say, well, a blood pressure systolic less than 100 or less than 80 must be providing us with some information without first understanding where would we expect that child's heart rate, blood pressure to be relative to their age. It's important, just if we start to think about what we expect, also to know that in the setting of even significant truncal trauma, the majority of children who come to our hospital, many of whom will have had blood loss, actually have normal hemodynamic parameters. They are hemodynamically normal, despite the fact that they have significant injury. So the normality of a blood pressure and a heart rate, and the stability of the blood pressure and the heart rate are reassuring as to the current status of the child, but shouldn't discourage us from synthesizing or in considering particular injuries in and around their trunk or elsewhere in their body. When we think about how we're going to resuscitate children, if they are losing blood, we should be replacing blood with blood or blood products. There is a significant debate as to whether blood transfusion should be in the form of a balanced transfusion with red cells, platelets and plasma given separately in various ratios, or whether whole blood is the best. But what we've gone right away from, because we understand that it can cause injury in the setting of severe trauma, is crystalloid resuscitation. It was been very well put by Phil Spinella, who said that salt water is for cooking pasta and blood is for saving lives. So if this child is bleeding, let's give blood or blood products, and I'll leave it to you in your setting to know which is the better, a balanced transfusion or whole blood. Moving one step down the prioritization of this systematic, structured approach is the assessment of a child's conscious state. And because some of the aspects of the Glasgow Coma Score can be hard to marry up against the age of this child, where perhaps incoherent speech is the norm. Perhaps the child is just so frightened they're not going to do as we ask. They might be withdrawing away from us as if they are showing poor GCS, but that might just be a response of fear. Because of all of this, we need to have an accurate way of assessing a child's conscious state. And we understand that the assessment of the conscious state is absolutely important for the child, because children who have these much larger heads relative to the size of their body, and therefore sustain many injuries in and around the head, either as a consequence of its size or the ways in which the size of the head can impact with a mechanism of injury, such as a whiplash injury, which can be devastating in a child, or a child being shaken, or a child being struck on the head. All of these amount to significant threats to the life of the child. And it is a sad truth that head injury is the #1 killer of injured children. So, bringing all of that back, we have to assess the conscious state. A Glasgow Coma Score is very important to the specialists, such as neurosurgeons, but can be quite challenging and doesn't necessarily impact the way in which people like myself, providing primary trauma care, look after this child. For all of those reasons, I and others recommend that we use the scale AVPU, A for alert, V for voice, P for pain, and U for unresponsive. And scoring a child on that 4-point scale is both informative as to the trend of their conscious state, and informative as to when their conscious state drops in a way that, were we measuring GCS, we would normally respond with an action. So, for example, the important GCS of 8, below which we perhaps might consider interactions such as safety of the airway, a child that has an AVPU score of either A for alert or V for voice is 100% positive predictive value of having a GCS above 8, according to reassuring research in this area. And I've highlighted the reference for you here, and you can see some of those results depicted. Right. What about the environment in which all this is happening in? Maybe you're at the roadside. Maybe you're in a hospital. Maybe it's a hospital that's used to receiving trauma. Maybe it's a hospital that's not used to receiving trauma. But wherever you are, is your department or your environment, is it ready for children, or is it actually upsetting for children? Is it rated R18+? Typical ways in which we can improve our environment, no matter where we are, is to improve the warmth. Yes, there's a discussion around hypothermia in trauma. Let's park that to one side and say it's not relevant specifically to this discussion. If the heaters in your environment aren't on, you need to turn them on. You need to turn them on as early as you can, because keeping this child warm will be important for their good recovery. It's a very busy environment. There are many roles that need to be filled to deliver a team approach to a structured, systematic delivery of trauma care. But that makes for a very busy place. So we need to ask ourselves, do we have everyone that we need? Do we have all the roles and the participants in this team that we require to deliver the care that this child needs? One of the forgotten members of that team are the parents. There is a great body of evidence that affirms that it is best practice to include the parents within the experience of this child's resuscitation. It is not for all moments, and it is not to be done without sensitivity and compassion. But please bring parents in and include them in and help them to understand the great care that their child is receiving from very committed clinicians. But in that busy environment, there may be people that you don't need. There may be people who perhaps are looking on but not contributing through a role. That is a crowd control that needs to be attended to. You need to ask those people respectfully to make way for those that do have something to provide. We think now about the tests that we do. Perhaps we should be asking ourselves, are our investigations R-rated, not just our department or our environment? And a really good way to think about this is our attitude towards CT scanning and trauma. The best evidence that I can bring to you, and I think the best way that we can think about the impact of CT radiation on children, comes from a study which was done within Australian young adults and published in the British Medical Journal in 2014. This longitudinal study identified that for every 1,400 CTs performed in young adults under the age of 20, for every 1,400 of those CTs, one of those young adults will develop a cancer in the next 10 years. And that risk increases incrementally by 16% for every additional CT scan performed. So it's really important that we understand that even though CT scanning has an important part in the assessment of the severely injured child, that it is qualitatively and quantitatively different from the part that it plays in the assessment of the severely injured adult. We strongly recommend that the idea of the pan scan be challenged in a child. By all means, you may make the active decision to scan each of the areas represented by a pan scan, but it should not be a simple decision to just get all of the scanning done at once because it makes it logistically easier or it somehow improves your assessments. It may not improve your assessments. It may prolong the child, deferring them from getting to the definitive care that they need, and it's exposing them to a level of radiation that could have significant consequences. And often clinicians, as I talk about this, they say, okay, well, who am I going to do a CT scan on? I want to flip that question around, and I want to say, I think it is best to define who you're not going to do a CT scan on. And one of the reasons I flip it around in that way is because of the various tools and rules that I've come across that help me in my practice in pediatric trauma. The rules around not doing a CT abdomen and not doing a CT chest, which come out of large multi-center North American trials, I think are the most useful. And I've given you the example here of a CT scan rule, which helps you to say no to an abdominal CT in the setting of severe injury. So if your child has none of the 7 features that are listed here, there is a negative predictive value of that child having a intra-abdominal injury requiring treatment that approaches 100%. These are negative predictive values and confidence intervals, which are just excellent and reflect the rigor of this project from which these data have been taken. And there's a similar CT guidance rule for CT chests in the same setting. And this is enabling us to safely say no to imaging a child. And we've looked in our own institution, and use of this tool would probably reduce safely, without missing injuries, our CT scanning rate by approximately 20%. Well, if CT radiation is an absolute no-no, and it should be done where it is required, but it should not be done where it can safely be avoided. What about ultrasound scanning? That avoids the radiation, it has greater traction. Unfortunately, ultrasound scanning, as it relates to fast scanning, has failed to stack up to the experience of adult trauma care. In children in particular, fast scanning lacks sensitivity, and this may be related back to what I said before about hemodynamic stability in this patient group. This is a patient group which does not usually present with hemodynamic compromise, and when fast scanning was delivered to adults who were injured who were not hemodynamically compromised, it also lacks sensitivity in that situation. But as many as 1 in 3 children who have a solid organ injury will not have free fluid on ultrasound. And there are a variety of reasons for that. It relates to clotted blood being echogenic, the obscuring of bowel gas, but there are many false negatives in the assessment of the child with a solid organ injury. There are also some false positives, because just because we find fluid in the belly does not mean there's an injury in the belly. And about 1 in 8 young children of both male and female genders, or male and female sexes, will have a physiological free fluid within their abdomen. And this is really important. It's also true that when we find some blood, if we say there is an injury and there is also fluid and it is actually blood and not just physiological, that does not in the child, because of the absolute success of non-operative management in those children for whom that is appropriate, who are the vast majority, the presence of blood does not mandate a next step. In many settings, it goes on to mandate a CT scan, which is perhaps one of the things we were going to be trying to avoid. But in that protocolized setting, it isn't even avoiding that potential negative. So one of the things I say about this is I think we should be going slow with fast in kids. But I'm looking forward to being able to turn that sentence right around and embrace fast when the ultrasound technology can provide us with a sensitive and specific answer. Well, I've just outlined to you some of the confusions that can arise, and another confusion that can arise in children is when they have deteriorations in their vital signs and development of their abdominal signs. Often, not always, but in too many times, these deteriorations of vital signs and abdominal signs are actually due to distension of either the stomach or the bladder. Kids are very prone to gastric distension, to gastric dilatation in the setting of acute trauma, so we must decompress the stomach. You can see here examples of undecompressed stomachs. This places the child at risk of a vomit, and in the setting of a vomit in trauma, the risk of aspiration and iatrogenic injury. Not only do we have to anticipate this and respond by the passage of a gastric decompression tube, we need to check that it's being effective. The picture shown here on the far left of your screen is showing a grossly distended stomach with a nasogastric tube in place. That is a nasogastric tube which has been spigoted, and that is only being recognized secondarily, and that child will have benefited from having their stomach decompressed. I feel that the debate between nasogastric and orogastric has validity, but it shouldn't be a validity that distracts or delays that child having their stomach decompressed. In most situations, a safe decision can be made between nasogastric or orogastric, and the priority is to decompress the stomach. As it is to decompress the bladder, in the same way we can see deterioration in vital signs with changes in abdominal features, confusing as to whether we have a patient who has perhaps a deterioration in their abdominal status with maybe bleeding into the abdomen, or are we dealing with someone in urinary retention? The answer given at CT scanning is often that the child is in urinary retention, that child should have had their bladder decompressed already, and if not, you should decompress it now. Finally, let's think about chest drain insertion or thoracostomy in children to decompress their pleural cavities. In the setting of trauma, this is a very important procedure. It can be life-saving or life-preserving, but it is actually often, very, very often complicated by error and new injury. So we don't want that. These children are injured enough as it is. But let me ask you, how confident are you as to where you're going to perform a thoracostomy and chest drain insertion, and how are you going to do that rapidly and safely to protect this child from ongoing injury? Well, I think that we can make pleural decompression easier in children for us as practitioners. And I want to just spend the last few minutes unpacking two tricks or tips that we've been able to establish in recent times to help you with this. Let's just be clear about what the problem is here. The problem is that we have air and blood outside the lung, inside the chest cavity. It's creating pressure. That pressure is dangerous, and we need to release it. So our number one priority is a thoracostomy to form a hole which lets that air and blood out, and that is going to save the life of this child. The number two priority is to put a chest drain in to keep that life, to keep that blood, that pressure from re-establishing. But the first priority is to form that thoracostomy, and we're going to hold those priorities through the discussion that follows. Now, we don't just in reality have blood, air, blood, sweat. We also have air, blood, sweat, and tears and fears, because actually when we look at this child, it is often completely confusing as to what we're going to do. Where are we going to cut? What are those anatomical boundaries of the safe triangle? You can't quite work out where you're going to be. You don't know what tube you're going to use. People start handing you things. They say, is this what you want? You think, I don't know. Let's dive into that moment of need and give you one magic number that you're going to use. Because without the magic number for chest drain, for thoracostomy and chest drain insertion, you're probably going to end up in the wrong hole using the wrong tube, and you're probably going to put your tube in too far. And that magic number, getting it right first time and getting it done quickly, is the magic number 4. And I want to tell you about the rule of 4s, which we teach here at the Royal Children's Hospital, and is becoming popular well beyond Australia into other parts of the world. So the first part of the rule of 4s is we're going to use 4-step plans, and we're going to use those 4-step plans to first form a good hole, which we're going to put in the 4th intercostal space. Why not the 5th? Because some people talk about the 5th. We're going to say 4th because you have one number to remember, the magic number, which is the number 4. So we're going to use our 4-step plans to first make a good hole in the 4th intercostal space, and we're going to use that hole and put through it a good tube. Now, many of you are involved in critical care delivery, and you'll be aware of the way in which we size an uncuffed ETT tube in children. And if you take that sizing, the formula for which is age over 4 plus 4, that'll be a familiar formula for many of you. If we take that 4-based formula and times it by 4, that is going to give us the good tube size that you're going to use in your injured child. So again, magic number, number 4. And we're going to do all of that, and we're going to insert the tube, and rather than just pushing it in as far as we can, which can lead to complication and reduce the effectiveness of a drain through kinking, we're going to start pushing it in, and then we're going to make our 4th part, which is our good stop. Where are we going to make that good stop? At the 4-centimeter mark on the tube. The 4-centimeter mark is not 4 centimeters from the tip of the drain. It is 4 centimeters from the last side hole, shown here in the various pictures. So it'll be a variable distance in according to the tube that you've used, but it'll always be a safe distance in our experience. So that's the magic rule of 4s. That is the magic number for thoracostomy and chest drain insertion. And you can see here various QR codes, which will lead you to papers and videos about how we do that. So 4 is the magic number. What is the magic trick for thoracostomy and chest drain insertions? And the magic trick relates to the mid-arm point. And this is something that other colleagues within Melbourne identified and popularized in adult trauma. It uses a point which is halfway between the olecranon and the acromion along the arm which is held by the side to begin with. And we then use that mid-arm point to mark the corresponding level on the chest. And we raise the arm into abduction and we have that abducted arm there, exposing the area of the chest and saying, right, this is where we make our mark. Wherever the mark on the skin is, that's where we make our entry. And when these colleagues from Melbourne looked at this in adults, they found that in 120 adults in whom they performed this technique, it showed a safe zone, which bridges the 4th to 6th intercostal spaces. Okay, we've talked about the 4th being optimal, but this is a zone of safety, the 4th to 6th intercostal spaces in 100% of those adults. And we asked ourselves, what about in children? Now, in children, we wanted to be able to perform this, and we did this through a prospective study. We used 4 sites, both within Australia and Ireland, and we looked at children between 0 and 18 years of age. We used the chest X-ray that the child was going to get anyway. These were uninjured children we recruited into this study, and we also created a video that you're seeing in the side here to help people understand the technique by which the mid-arm point is used. And you can see here, we've gone to the mid-arm point, and we're now going to swing it round and place the mark, not on the arm, but corresponding to the level of the mid-arm point on the chest. And in a moment, when I raise this child's arm away from their chest into abduction, you will see that the mark will go up ever so slightly, and then we'll be ready to put the chest drain in if this were an injured child, but it isn't. We did this in almost 400 children, and we found that 8 out of 10 times this identified a place within the safe zone. So it didn't perform as accurately as in the adult series. But when we looked at the data, we found that as in older children, there was a tendency for the mark created by the mid-arm point to be a bit too caudal, a bit too low. And we considered if there was, in fact, some growth changes which were playing a part here. The arm in a child grows in a linear fashion, whereas the chest in a child grows in a curvilinear fashion, in more of a logarithmic fashion. And for these reasons, we considered the fact that in older children, it might be necessary to go up 1 intercostal space. So we redid our analysis as if we were going to go up 1 intercostal space. And we looked at what would be the ultimate cutoff. And very excitingly, we found the ultimate cutoff, optimal cutoff shown by statistical analysis, was 4 years of age. So for a child 4 years or more, up until the adult age of 18, we recommend that you go up 1 intercostal space and into the space above the mark. And when we adjusted in this way, we now found that 9 out of 10 times the mid-arm point was providing entry into a safe, into the safe zone, the 4th to 6th intercostal spaces. And we published this experience, and you can see here the reference and the QR code. We termed this adjustment according to age the MAPED rule, and you can see it shown there that in a child under the age of 4, the mid-arm point alone will get you to the safe zone. But in 4 or more years of age, go to the mid-arm point and go up 1 intercostal space, and that will bring you into the safe zone. Now, I hope that one day you're going to be doing a thoracostomy or chest drain insertion on an injured child, and both the magic number 4 and the mid-arm point in children will assist you deliver that child safe and rapid care the way that they need so. Remember, the mid-arm point was only accurate in 9 out of 10, showing on target. So it's not foolproof. You do have to have your brain in gear as well. So thanks for your time, and I hope that you've enjoyed a bit of a run through pediatric primary trauma care. It's a lot to cover, but I hope that in that time you've been able to see things that will help you care for children who are injured. If you would like to reach out to me, I'm available on email, and the details for which are provided in the slides which accompany this presentation. Thank you for your time.
Thank you, Warwick. I mean, a very important topic. So yes, I can understand people needing to say lots more information. So I'd like all the panelists to switch on their cameras and thank all the panelists for their contribution to this webinar. We will take questions. Some of them have already been answered in the question and answer session, but I'd like to make one very important point that, you know, as pediatric surgeons, we fall between stools of the pediatricians and the adult surgeons. And that very point you made about saltwater resuscitation, in about 2002, the pediatricians made a huge drive that all children should be fluid restricted and given salt because they look at septic shock. What they didn't speak to were the pediatric surgeons where we see hypovolemic shock. So you need blood and you need fluid. And a lot of children suffered because that was published in a very high impact journal. And similarly with the adults, they make blanket rules without a discussion with us where, you know, every child, every patient, adult patients that comes in now gets a CT, whether trauma or not, or, you know, all liver and splenic injuries were managed operatively, whereas we don't. And I think, you know, we are pushing hard, even in GICS, to break into the adult arena where they are making these rules and break into the pediatric arena where they're trying to make these rules, avoiding what is important for children with injuries and so forth. So there's a question up here for Abdelbasit to say that, do we have country leads for trauma so people can start working together, or regional leads?
Right, thank you very much, Kokila, and thanks to Dr. Han for that question. Yeah, the initial plan for GICS is to have country leads, and then even within the country, we can have like regional or distribution of other helpers to the lead. But we thought initially, because it may be too diffuse, to allow the local people to volunteer and take the initiative and pick it, and then adapt it and implement it within their own situation. So they can assess the situation and take it further according to their own, and then later on feedback their experience. And everyone is welcome to join the group, the GICS Trauma Working Group.
Thank you, Abdel. A question for Warwick from Laura regarding, is there literature about soft collars?
There is. It's quite a lot, and I just saw that question from Laura. There's a lot that's written about this in various ways, and I think one of the it's called EMCAST did a good summary about the debate between soft collars and hard collars. And I know that our hospital recently did evidence-based review and a review of our clinical practice guideline. I think that has some references towards the end. So that's very available through the Royal Children's Hospital website. But I imagine actually that many of our hospitals have similar resources. Yes, it's the assertion that hard collars don't immobilize and that hard collars have complications that are avoidable is very evidence-based statements, and that is particularly in the younger children, hard collars are typically not fitting them at all well, and so therefore a great cause of problems. So both adult and pediatric spinal restrictions have gone all the way to soft collars throughout Australia now. I think New Zealand as well, and I'd be interested in other groups to talk about what they're seeing in their countries. But it's very clear for us at the moment.
Thanks, Warwick. There's a statement from Dr. Holterman regarding a prepared trauma course that they have, and I'll claw in Abdelbasit and Sabina to talk this through. But in GICS, what we've been doing is that, you know, there are courses run by many different groups, and we tend to kind of go through them and see if they're applicable to the type of work that GICS is doing. But would you like to answer to that, Abdel?
Yeah, thanks, Kokila. Yeah, as you correctly said, we've realized that there are so many courses around about the trauma management, the advanced trauma life support, the primary trauma care foundation and its course, which is taking place in many parts of the world, maybe over 180 countries. And we have reached out for the primary trauma care foundation to try and liaise with them so that their course can include part of it more doses about pediatric trauma care. And we have agreed that we are going to prepare our own GICS trauma, pediatric trauma course. And it's underway now, and it's going to be ready for the next GICS physical meeting. Maybe that's planned to take place in the Philippines next year. So until then, we will try to find out whether this course can be distributed for local champions to take it and then use it locally. Because I don't think we'll be having the resources from GICS to move around the world and do the course there. But hopefully that will be ready and be specific for pediatric trauma.
Thank you, Abdel. I think the question regarding ATLS is answered by you already, because the primary trauma care course does align itself mainly for resources available in low and middle income countries. So that is the course that is more functional on the ground, rather than the ATLS that has a lot of high equipment, which is not available in low resource countries. So I'll just move on to the next question about that. Are there any kind of a trainer's course that can be developed by GICS so that we have a standardized way of working, knowing that GICS is a broad organization that involves a multidisciplinary team involving children's surgical care?
Yeah, that's a good idea. Yeah, for the first part, I mean, as you correctly said, we don't need to reinvent the wheel. There are courses there which we need to boost with enough doses of pediatric surgery. But until we make our own course, and if that works well, then we'll take it from there to make a course for training for trainers and training of trainers, and then take it further from there.
A question from Megan about resources of, do we have resources for trauma care, and where can it be accessed?
Yeah, for GICS, we have the trauma prevention leaflets. They are uploaded on the GICS website and the special resource area. But other than that, we are happy to help the colleagues from anywhere by reaching out to organizations that can give help. I mean, GICS has got many links with many active organizations on the ground. For instance, the Kids OR and many other organizations. And through those, we can see how we can help our colleagues who ask for any specific requirements.
I'm going to direct.
But otherwise, no, we do not have material as such to help with, especially tools, instruments, and equipment. Maybe in the future, we can also help with the production of guidelines.
Thanks, Abdelbasit. Farid has put a question, and I'm going to direct this one to Soji, that in a lack of pediatric trauma center, who can provide the trauma care for the children?
Thank you. I think this question speaks to the need for a trauma team. And I think it depends on the competencies of the people who are available. So if there is no trauma center and there are doctors there, to the level to which they can attend to, those doctors should. In places where there are no doctors, whichever health worker is available and can render initial treatment should do that. And I think that's also an issue for us to think about in the trauma committee, that in our courses are not only going to be directed at only core doctors or surgeons, but we should also include other health workers in the health team such that they can render the initial resuscitation before they get to a place where more complex interventions can be done. Thank you very much.
Okay. There's a question from Doruk that one of the biggest problem is the lack of funding. And is there something that is a quick fix, something in first aiding or something in prevention that we can drive our funding towards? And I'll direct that question to Simone.
Thank you, Kokila and Doruk. I think that the most low cost and effective tool is to work on prevention, and but it's not fast. But the results are not fast. But I think that we should work on those, and also to provide advanced pediatric care resources that are also low cost. So everywhere you should have a list, and GICS has already provided a list of that. And this is low cost, because if you don't have adequate material, the child is going to die. And also adult surgeons, as Soji was saying, I think that everybody has to be trained on pediatric trauma care, because the scenarios are so variable. And so whoever does the first care should be able to do that on a child. And providing training is another thing that can take time, but it's very effective too. So I think that education and some basic resources, both on prevention and training in pediatric care, are things that might be a very important and effective things to do. I don't know if I answered that.
I think you've answered. I think what you're looking at is the broader picture of a system of education, a system of prevention. But I'm going to direct the same question to Warwick, where at the point of care, what funding would you want so that it will have the maximum impact in saving lives?
Oh, that's a really tough question, Kokila.
It's a loaded one.
Look, I think that what I absolutely agree that investing in prevention is going to save the most lives, because whether I've got a fancy machine or more staff or whatever else, they're all going to be helpful, but the lives will be saved by the child never being injured. But one thing that I think hinders our efforts to do that is a lack of data. And so if I was going to start to sort of theorize and philosophize around what we could fund, I think much better data management. Simone's shared excellent data with us, and we have data from Victoria and other places will have good data as well. But even with those excellent data sets, to drill down and to have geospatial mapping and to have emerging injury causes captured. E-scooters come along, no one knows how to code them, and all of a sudden we don't understand what the injury causes of those are. So there are lots of different things. So I would be investing in prevention, and I'd be investing in what really accurate, highly sort of mobile data. I think that having resource teams in hand is great. Having courses and promoting people to be able to travel towards education and have that education made freely available. These are all highly laudable things. We should do all of that. But I think that data and excellent epidemiological research is constantly slipping through the gaps.
Thanks, Warwick. There's a statement from Philippines. Beda Espineda, our colleague and representative from the Philippines for GICS, has said that at the conference that we are going to be holding in 2024, can we have a session for pediatric trauma care for general surgeons? Because in Philippines, most of the frontline care is done by adult teams. So if we can have, education for our adult colleagues in pediatric care. I mean, we are doing it in some of the other pediatric conditions, but I think trauma does, come right to the top of that.
Yes, yeah, Kokila, I think that's a good idea. And we can have a session on trauma at that meeting, and then we can invite our colleagues from general surgery. But if you just allow me just to go a little bit further about answering the last question.
Sure.
As Simone mentioned, there is a list of requirements. So in addition to educating the public and the healthcare workers as to how to deal with the problems primarily at the scene and trying to improve the situation with the ambulances, once the patient arrives in hospital, there should be at least the basic requirement, and the WHO has issued a list of essential requirements that should be available in every emergency department. We have got a modified list, which we can share if anyone wants that. And it's actually based essentially on low and middle income countries requirements. And those requirements, once available, sure, they can help a lot in managing many of the severely injured children coming first time to ER, if people are prepared for that. Thank you.
Thanks, Abdel. There's another comment from Milan Chitness to say that Sebastian van As from Cape Town has started a child-safe preventative program working with the taxi drivers. And I think the group in Johannesburg is doing the same. And I think there's a group in Kenya working with the taxi drivers, because that is the biggest cause of pedestrian accidents for children. So thank you, Milan, for highlighting that. I think, I thought we'll go up to 2:30. We've got 3 minutes, and I thought just quickly, if the panelists would want to just give their last pearl of wisdom to the audience, 30 seconds each, just a punchline before we close the meeting. And just to remind everyone that a survey will be sent to you. At the receipt of the survey by the administrative team, you will be awarded a certificate with CME points. So I'll start off with the first speaker. Soji, a quick...
Thank you very much. I think the essential thing for me is that GICS is on the right path by bringing a lot of awareness, and we should continue to do that work. One day it will pay off. Thank you.
Thanks, Soji. Abdelbasit?
Thank you, Kokila. And I would like to thank all my colleagues who participated in this activity and the audience as well. From the Global Initiative Children's Trauma Care Initiative, I would like to invite all junior colleagues in particular to embrace the initiative and try to take it further, because there are specialized colleagues in adult trauma, but this specialty is still crawling in pediatric surgery. So if we can encourage more people to be involved and to take this further as an ownership. Thank you very much.
Thanks, Abdel. Simone?
Thank you. And thank you all for participating. I think that we have the responsibility to highlight the importance of pediatric trauma, because when you see trauma numbers, if you compare adult trauma numbers to pediatric trauma numbers, people will say, why should we bother about that? But this is the main cause of death for children and brings enormous problems for society. So do work on this, because everything in the child has long-term consequences, and do work on prevention. As surgeons, we really find it difficult not to see our work, because we want to open, do something and close and it's there, and prevention is not like this. But if you were able to save even one child's life, it will be worthwhile. Thank you.
Thanks, Simone. Warwick?
Totally agree, prevention. But taking up my theme, I have learnt so much about primary trauma care from adult practitioners. I think that adult practitioners have a great deal to offer, and we now are privileged to give back into that same cohort, the pediatric skills that we bring for these precious children and their families. So I would like to encourage everyone that what you have learned about adult trauma or trauma in general, there is so much richness in what you've learned. And hopefully what we're offering in is the perspective of the importance of prevention and the pediatric nuances. And I think that in that is a wonderful fertile ground for great care.
I think the final bit that I would say is, just to reverberate what Simone said in her slide, that prevention is a vaccination for trauma. So let's push the vaccination. And like in the pandemic, there's such a lot of hype about the vaccination. We can achieve this by really driving the preventative element, because then it avoids so many of what we are seeing now and that we feel so uncomfortable with. So in the end, I'd like to thank everybody, the panelists, as well as the participants who were really interactive in their questions, for Sabina for running the education program for GICS, Abdelbasit for being the lead for GICS, and not forgetting Maggie, who did all the work in the background. So thank you, everybody.